Hey, what about the non-degenerative reasons for hip replacement? What was the problem with the 12-year-old that you mentioned earlier on? What were you looking for there? And again, I'm thinking about this in the context of my colleagues, the people watching, when they get somebody of that age who might present to them thinking this is a simple physical therapy problem when actually there's something more serious underlying.
Yeah, I mean, and that's a good point. And I think that when I talk to therapists about hip problems in young patients, I often stress that early and simple imaging can be extremely helpful in really delineating what the underlying problem is, even if it doesn't necessarily deviate them from whatever treatment pathway they're following. So, I mean, I would argue, I mean, the patient I was talking about actually had bilateral hip dysplasia as a young baby and attempted treatment which hadn't worked and had led to avascular necrosis of both hips. And she was extremely disabled by it. So, you know, that was the reason in her case to have surgery. And often the much younger patients do have a history of either structural disorders of the hip that can be more systemic, or childhood hip problems such as Perthes or SUFI or things like that, which can intervene. But it's also true that there are some young hip disorders which are worth picking up early because they have consequence. And you know, I see and treat a lot of what I might term adolescent and young adult hip dysplasia, which is, I think, a slightly different phenomenon from what you might pick up at birth. That can lead to quite significant hip pain and early arthritis, and is worthy of early investigation in the setting where the symptoms aren't settling as you might expect. You know, there's a long tradition of non-arthritic hip problems being treated as groin strains or similar for a long time, because I think not just amongst, obviously, you know, GPs and therapists, also amongst orthopaedic surgeons who don't treat it very often, you know, a lack of recognition of the potential underlying anatomical anomalies. And so part of my role is not only, you know, if patients are sent to me, it isn't the case that I will then offer them surgery. I will often investigate them, try and understand the underlying biomechanics if they think they're relevant, and then often package that patient's problem up in a slightly different way to go back to the therapist, because not every hip problem will need the same approach. And sometimes understanding whether there is instability in the hip, such as dysplasia, or for example, impingement, which is perhaps a more recognized phenomenon amongst the listeners, you know, there is a very different approach to those sorts of things I'm sure that they would take, and therefore understanding what's going on will help everyone in their treatment pathway.